BTK inhibitors are approved as single agent therapies, and they're continued forever, as long as patients are tolerating and getting a good response. So some of the questions include, can we use these agents more in frontline? What combinations produce deeper remissions and potentially allow for limited therapy? So if we have 2 and 3 drugs that we use for a year or 2 years and are able to achieve deep remissions or minimal residual disease, what's called MRD negative remissions, are patients able to be on these therapies for a shorter amount of time instead of continuing forever? That obviously helps with the patient not being on therapy, decreases long-term toxicity and decreases cost. If patients do that, are they able to be retreated with these therapies? So if they get a deep remission and are on therapy, combined therapy for a year, and they relapse in 2 years or 5 years, are we able to retreat and able to achieve a remission again with those therapies? And then just in some of the diseases like mantle cell lymphoma, where it's used uniformly in the relapse setting, but doesn't have an approval in the frontline setting, how can we add these to frontline therapy to improve outcomes in those patients?